welcome to the Journal Club. It's 7 a.m. here in the United States. Happy New Year, everyone. We'll be kicking off today's Journal Club with some good studies, hopefully with some practical and some scientific importance. So we will get started. So our first study is a study published in Clinical Gastroenterology and Hepatology. It is that COVID-19 vaccine is effective in inflammatory bowel disease patients and is not associated with disease exacerbation. So this study is important in our clinical practice because various factors may interfere with host response to COVID-19 vaccination, such as advanced age and various types of immune suppression, such as immunosuppressive medications. And recent reports have suggested that there may be impaired serological response to COVID-19 infection in patients treated with TNF inhibitors and immunomodulators and impaired serological response to vaccinations. Therefore, concerns exist whether the new COVID-19 vaccines are effective in IBD patients, especially those treated with immunosuppressants. Immune activation due to COVID-19 vaccination would trigger IBD exacerbation. The aim of the study is therefore to evaluate the effectiveness of COVID-19 vaccination in IBD patients and to look at the effect of COVID-19 vaccination on disease activity. So this was a population-based study from Israel using the Israeli IBD Research Nucleus Cohort. And they also used the data from the Israeli Ministry of Health, which has a central online system for registering patients who have undergone COVID-19 vaccinations and also their COVID PCR results. And this was a national vaccination program was started in Israel on December 1st, 2020. So IBD patients were matched with non-IBD patients, and also one vaccinated IBD patient was matched to one vaccinated non-IBD patients. The primary outcomes were to compare COVID-19 infection rate in IBD patients versus non-IBD patients, and to compare COVID-19 infection rate in IBD patients treated with TNF inhibitors alone or with corticosteroids alone or in combination at the time of vaccination versus non-TNF inhibitor corticosteroid treatment group, and also to compare IBD vaccinated patients with non-vaccinated IBD patients to compare IBD activity. So an exacerbation was defined as treatment escalation, commencement of corticosteroids or systemic or enema or hospitalization. So as you can see, they matched 4,900 IBD patients with 4,900 non-IBD patients. As you can see, 4% were on corticosteroids around the time of, within the preceding year of the study, and 10% were anti-TNF treatment. They also matched 707 vaccinated IBD patients with 707 non-vaccinated IBD patients. And here are the study results. As you can see, when you're looking at the positive PCR rate, so this would be taken as the COVID-19 infection rate, there was no significant difference in patients who had IBD and non-IBD patients. Also, if you're looking at the COVID-19 infection rate, there was no significant difference in patients who had, among patients with IBD who were on anti-TNF treatment and steroids versus patients who were not on anti-TNF or steroids. Also, encouragingly, COVID-19 infection rate was not different between patients who were on anti-TNF and steroids versus any other treatment that was not anti-TNF inhibitors. When you're looking at the risk of IBD exacerbation, at median follow-up of 14 weeks, the rate of exacerbation in the vaccinated IBD group was 29%, and the rate of IBD exacerbation in the unvaccinated group was 26%, with p-value of 0.3 And so there was no significant difference between the two groups. The limitation of the study is that this was a retrospective study with inherent risk of bias associated with retrospective studies. And also, this is a matched, this is a case control study, essentially, with matching of groups in patients with IBD and those who were vaccinated and non-vaccinated among the IBD group, and patients with and without IBD. And within the matching process, the risk does exist that some hidden confounding variables were not included. Also, the low infection rates in vaccinated study subjects in patients with IBD does limit the statistical power to prove equivalent effectiveness between the two groups. However, the support that the vaccine was highly effective in both groups. So the take-home point is that the effectiveness of COVID-19 vaccine in IBD patients is comparable to that of non-IBD controls and does not appear to be influenced by treatment with TNF inhibitors or corticosteroids. The rate of IBD exacerbation also did not differ between vaccinated and unvaccinated IBD patients. Our next study was published in Gut by Lau et al. This is the risk of post-colonoscopic polypectomy bleeding and thromboembolism in patients treated with warfarin and direct oral anticoagulants. The study is important to our clinical practice because management of anticoagulation in patients undergoing invasive procedure remains challenging, with difficulty managing bleeding risk versus thrombotic risks. The use of anticoagulation has been associated with significant high risk of post-polypectomy bleeding. But there are currently conflicting data on the risk of post-polypectomy bleeding between patients taking warfarin versus other novel direct oral anticoagulants. The aim of this study was to evaluate bleeding and thromboembolic risks after colonoscopy and polypectomy in patients on anticoagulants, including warfarin and direct oral anticoagulants. So this was a retrospective study, again from Hong Kong. They used the clinical data analysis and reporting system of the Hospital Authority in Hong Kong, which is an electronic healthcare database system that records patient health information from all the public hospitals in Hong Kong, which covers about 90% of the population in Hong Kong. Adult patients undergoing colonoscopy or sigmoidoscopy and polypectomy between January 2012 and June 2020 were included in the study. The active use of oral anticoagulation was defined as endoscopy procedure performed between the start and end of the drug prescription for the anticoagulant, or within 7 days of the prescription end date, or within 30 days of the next prescription start date. The primary outcome measure was to look at the incidence of delayed post-polypectomy bleeding, which was defined as the need for repeat colonoscopy and hemostasis to control bleeding within 30 days of the colonoscopy. So what they ended up including were 3,887 patients who were active oral anticoagulant users who had undergone endoscopic polypectomy. And as you can see, the majority of the patients in this cohort were on warfarin, just over 2,000, 510 on apixaban, 604 on dabigatran, and 526 on rivaroxaban. And this is the incidence of post-polypectomy bleeding in patients who are on warfarin versus other direct oral anticoagulants. So as you can see, when you're comparing the risk of bleeding in patients taking warfarin versus rivaroxaban, there is no difference in bleeding risk between these two agents. If you look at the incidence of bleeding with apixaban and dabigatran versus warfarin, there was a difference in bleeding between these two groups, with much lower risks seen with the direct oral anticoagulants, apixaban and dabigatran, compared to warfarin. When looking at the post-polypectomy bleeding instance between the different direct oral anticoagulant agents, you can see that there was a significantly lower risk of bleeding with apixaban versus rivaroxaban, with p-value of 0.001, and the p-value for other comparisons between these three agents was not significantly different, with p-values of 0.05. When then looking at the risk of thromboembolism, when looking at the incidence of post-polypectomy bleeding with warfarin versus the direct oral anticoagulants, as you can see, the risk of bleeding was significantly lower, the risk of thromboembolic events was significantly lower with apixaban compared to warfarin. However, when you look at the risk of thromboembolism of the other direct oral anticoagulants such as dabigatran and rivaroxaban with warfarin, there was no difference between thromboembolism rates. Again, when looking at the thromboembolic risk between the different direct oral anticoagulants, as you can see, the lowest incidence of thromboembolism, again, seen with apixaban, and this difference was significantly different when you're comparing apixaban with rivaroxaban, with p-value of 0.022, and when you're comparing the other combinations of different direct oral anticoagulants or different comparisons between the direct oral anticoagulants, the p-value is greater than 0.05. The limitation of the study is that, again, it's a retrospective study. They were unable to retrieve all the records for the endoscopic resection technique, which may have affected post-polypectomy bleeding risk. As you already know, there are some currently available risks that cold snare polypectomy techniques, especially for large lateral spreading lesions, does appear to confer lower bleeding risk compared to using hot snares. Also, they had no data on prophylactic clipping, which can also affect the risk of post-polypectomy bleeding. And also, there was no information on the time of interruption or resumption of these anticoagulant agents after after polypectomy and prior to the colonoscopy. Also, the data on severity of bleeding were not available in this study. So the take-home points from this study is that apixaban, which is a direct oral anticoagulant, was associated with a lower risk of bleeding and thromboembolic events compared to warfarin, and also rivaroxaban after colonoscopy and polypectomy. Therefore, special attention is needed for anticoagulation management in high-risk patients, such as older patients and patients undergoing resection of right-sided polyps. So this is our third study. It's published in Hepatology, and these authors found a way of methylation markers in bile for early and accurate detection of cholangiocarcinoma in patients with primary sclerosing cholangitis. So this study is important in our clinical practice because primary sclerosing cholangitis is a chronic cholestatic liver disease that can lead to end-stage liver disease, and PSC patients have been reported to have up to 600 times increased risk of developing cholangiocarcinoma, which confers to about a 20% lifetime incidence of cholangio-CA. And cholangiocarcinoma is challenging to diagnose in PSC patients. Now, aberrant DNA methylation alterations are highly prevalent in most cancer types and can be detected in body fluids. And in cholangiocarcinoma, aberrant DNA methylation has been observed in blood and bile. So the aim of the study by these authors was the validation of DNA methylation biomarkers in small volumes of bile for early and accurate detection of cholangiocarcinoma in patients with PSC using droplet digital PCR methods. So this was a multi-center study of 273 patients who were diagnosed with a variety of hepatic diseases. Some patients had cholangiocarcinoma with and without PSC, PSC with dysplasia. Diagnosis of dysplasia was based on brush cytology, PSC without malignancy, and other benign liver diseases. And bile was collected during ERCP in the majority of cases, and also at liver transplantation and liver resection in a very small minority of the patients included in the study. DNA was extracted from collected bile, underwent bisulfite treatment, and then they performed DNA methylation analysis using droplet digital PCR system. They looked for and analyzed for 4 markers: the cysteine dioxygenase type 1, cannabinoid receptor interacting protein 1, septin 9, and vimentin. And these are the results. So they were able to find 38 patients who had cholangiocarcinoma who had concurrent PSC, and also 205 patients with PSC. As you can see above, about 60% of patients had underlying UC, and about 13 to 14 patients had underlying Crohn's disease. The majority of patients did not have cirrhosis. The median CA 19-9 level was 47 in the cholangiocarcinoma group and 19 in the just PSC group. Now, what they did was they looked at the area under the curve in these patients. So first, they compared patients who had cholangiocarcinoma, and they also looked at patients with just PSC, and they looked at the sensitivity and specificity, essentially, of these 4 markers in being able to diagnose cholangiocarcinoma in patients with PSC, and they found the sensitivity to be 79% and specificity of 90%. When they narrowed the analysis to patients who were diagnosed with cholangiocarcinoma within 12 months of bile collection compared to PSC patients without cholangiocarcinoma, they found that the sensitivity of these 4 markers in diagnosing cholangiocarcinoma was 100% and 90% specificity. When they included patients with only long-term follow-up availability and looked at the sensitivity and specificity of these markers for being able to diagnose cholangiocarcinoma within 12 months of bile collection, again, sensitivity and specificity were high at 100% and 93% respectively. The main limitation of this study is that it's relatively small sample size, and therefore results do require validation in large studies. I know this is kind of a translational research type of study, but I think the important thing about this study is that it shows that using droplet digital PCR technique to test for DNA methylation biomarkers in bile was able to detect cholangiocarcinoma in patients with PSC with high sensitivity. And so these findings suggest that these biomarkers have the potential role to complement standard modalities for improving cholangiocarcinoma detection and surveillance in PSC patients. Next is a study published in Clinical Gastroenterology and Hepatology looking at non-contrast MRI for detecting hepatocellular carcinoma. And this is a systematic review and meta-analysis. So this study is important in clinical practice because hepatocellular carcinoma results in more than 800,000 deaths per year worldwide, with advanced cancer associated with essentially no treatment options and poor survival. So routine surveillance of individuals with known high-risk factors for HCC is therefore recommended to improve patient survival. Now, the current recommended surveillance modality for HCC includes essentially transabdominal ultrasound, but that can have variable quality depending on patients' body habitus, liver position, presence of bowel gas, heterogeneous liver parenchyma, appearance in cirrhosis, increased liver echogenicity and hepatic steatosis, and then if there are confounding liver lesions present, such as hemangiomas and regenerative nodules. The other considered modality tools, surveillance modality tools for HCC includes contrast-enhanced CT with the risk of ionizing radiation exposure, especially if the surveillance has to be continued long-term, and contrast-enhanced MRI exposes patients to gadolinium. So currently, there are no guidelines that offers non-enhanced imaging for HCC surveillance. So what these authors wanted to do was to evaluate the operating characteristics of non-contrast MRI for HCC detection compared with patients who already had histological diagnosis for HCC or HCC diagnosed on the current recommended contrast-enhanced CT or MRI scans. So this was a systematic review and meta-analysis. They were able to include 22 studies comprising 1,685 patients and over 2,000 lesions. 19 of the studies were retrospective and only 3 were prospective. And they included non-contrast multi-sequence MRIs and non-contrast diffusion-weighted MRI imaging. And this is the result. So first, looking at the pooled sensitivity and specificity, when you're looking at the multi-phased non-contrast MRI, the sensitivity for detecting HCC was 0.87, and pooled specificity was 0.9. When you're looking at the DWI only non-contrast MRI scan, the pool sensitivity and specificity were 0.79 and 0.97 respectively. When looking at the pooled likelihood ratios for multi-phase non-contrast MRI, it was 0.17 for negative likelihood ratio, and positive likelihood ratio was 7.23. Again, for DWI imaging, pooled negative likelihood ratio was 0.24 versus pooled positive likelihood ratio of 17.46. Now, when looking at the area under the curve, which essentially measures sensitivity in the y-axis and 1 minus specificity on the x-axis, and essentially larger the area under the curve, the better your test is at detecting a particular disease process. As you can see, the area under the curve was high, 0.93 for both multi-phase non-contrast MRI and DWI only non-contrast MRI. In patients with cirrhosis, the operating characteristics were also fairly good when looking at the multi-phase MRI, non-contrast MRI. Pool sensitivity was 87% with specificity of 82%. And when looking at the DW MRI, sensitivity was 71% versus specificity, and specificity was 97%. Now, when looking at the pooled sensitivity according to lesion size, the sensitivity was also fairly good for small lesions less than 2 centimeters, with pool sensitivity of 77% compared to lesions who are greater than 2 centimeters, in which case the MRI, non-contrast MRI scans performed a little bit better with pool sensitivity of 88%. The main limitation of the study is that histopathological diagnosis was not used universally in all the studies as the diagnostic modality for HCC, and some patients used contrast-enhanced imaging as reference standard instead, which does in some ways reflect real-life practice. There was no analysis on cost effectiveness in this study. The third limitation is that most included studies did not include a true surveillance population, and many of the studies actually were performed on patients who underwent MRI for indeterminate liver lesions or had liver MRI for other reasons. The take-home points from this study is that this meta-analysis shows that non-contrast MRI has acceptable sensitivity, high specificity, and moderate negative likelihood ratio in the detection of ACC, even in the presence of cirrhosis and for small lesions less than 2 centimeters in size. And further prospective studies are obviously required to validate the non-contrast MRI for surveillance of ACC in high-risk patients, especially when sonographic visualization is suboptimal. Our last study is published in Gut, and it's a randomized trial looking at the role of pneumatic dilation for persistent dysphagia after anti-reflux surgery. Laparoscopic fundoplication is considered to be the most effective treatment for patients who are non-responsive to PPI in patients with GERD. Postoperative dysphagia is a common side effect after laparoscopic fundoplication and can persist in up to 25% of patients, which can then ultimately affect quality of life and oral intake. The management of persistent dysphagia after fundoplication, but patients with no anatomical defect, is challenging, and there are no optimal evidence-based treatment options available. Some retrospective data do suggest possible efficacy of pneumatic dilation with positive effect in about 2/3 of patients. The aim of this randomized trial was therefore to evaluate the effect of pneumatic dilation in persistent dysphagia after laparoscopic fundoplication. So this was a multi-center randomized single-blind sham-controlled trial conducted between 2015 to 2020. It's a relatively small study with only 42 patients enrolled who had persistent dysphagia greater than 3 months after laparoscopic fundoplication, and those with Eckhart score of 4 or more. Patients were randomized in a 1-to-1 ratio to either pneumatic dilation using a 35mm balloon, and versus sham dilation under deep sedation. So sham dilation group basically had no dilation. They just had an upper endoscopy, and the endoscope was placed in the stomach for about 5 minutes to keep the procedure duration similar between the two groups. The primary outcome was treatment success, defined as Eckhart score of less than 4 and at least 2-point reduction Eckhart score after 30 days. So these are the treatment outcomes. So ultimately, 20 patients were included in the pneumatic dilation group, 19 in the sham dilation group. 21 patients in the pneumatic dilation group and 21 patients in the sham dilation group. And if you look at the treatment success, if you're looking at the intention to treat analysis, it's standard for randomized trials, as you can see, the treatment success rate was 33% in the pneumatic dilation group compared to 38% in the sham dilation group, with no significant difference between the two groups. If you're looking at the median Eckhart score between the two groups, there was also no significant difference. It was 3.5 in pneumatic dilation group versus 4 in the sham group. Also, there was no significant difference in the IRP pressures in esophageal manometry in these two groups. Also, there was a little bit of a difference, some difference in stasis after 1 minute when looking at timed esophagram at 1 minute, but overall when you're looking at 5 minutes, the length of column after 5 minutes, there was no difference within two groups. These p-values all reflect the differences in quality of life between the two groups. As you can see, there is no difference in quality of life between these two groups, including symptom severity, symptom frequency, heartburn, regurgitation, GERD symptoms, dyspepsia, physical health, and mental health. The limitation of this study is the small sample size, only 21 patients including in each group. And also of note is that 8 of the 39 patients enrolled with the final follow-up results had status on esophagram at study enrollment, and therefore possible selection bias with inclusion of patients with functional dysphagia in the study. There was no information on body weight in the study, and therefore we're not quite sure how significant the dysphagia was, whether this resulted in weight loss, and also the relatively short follow-up duration of 30 days. The main take-home point is that in patients with persistent dysphagia after laparoscopic fundoplication, pneumatic dilation was not more effective than sham therapy. So there is no rationale for performing pneumatic dilation in these patients without any objective metric of obstructive or anatomic defect. To recap, the effectiveness of COVID-19 vaccine in IBD patients is comparable to non-IBD controls and is not influenced by treatment with TNA inhibitors or corticosteroids. Rate of IBD exacerbation did not differ also between vaccinated and unvaccinated patients. Secondly, apixaban was associated with a lower risk of bleeding and thromboembolic events than warfarin and rivaroxaban after colonoscopy and polypectomy. Therefore, special attention is needed for anticoagulation management in high-risk patients, such as those patients aged over 70 years and right-sided polyps. Using droplet digital PCR to test for DNA methylation biomarkers in bile was able to detect cholangiocarcinoma in patients with PSC with high sensitivity. These findings suggest that these biomarkers have the potential to complement standard modalities for improved cholangiocarcinoma detection and surveillance in PSC patients. In this meta-analysis, non-contrast MRI had acceptable sensitivity, high specificity, and moderate negative likelihood ratios in the detection of ACC, even in the presence of cirrhosis and for lesions less than 2 centimeters in size. And further prospective studies are needed. In patients with persistent dysphagia after laparoscopic fundoplication, pneumatic dilation was not more effective than sham therapy. Therefore, there is no rationale to perform pneumatic dilation in these patients without any objective metric of obstruction in the esophagus or anatomic defect. Thank you very much. Our next journal club will be on February 2nd, 2022. It will be the first Wednesday of February. Thank you so much for joining us again today, and please have a wonderful day and week, and again, Happy New Year. Thank you so much.